Thank you. I think the point that Dr. Shenoy made at the end of the last session is critical. I think what you need is a dedicated surgeon who has fully vested interest in making sure that the surgery that they do results in a productive, functioning fistula. And this fistula will serve the patient as a valuable lifeline for the length of time that the patient is on dialysis. So when Dr. Shenoy and others like Dr. Shenoy in the country in the United States will do such a fistula, you see a 90–95% primary maturation rate. But yet, the data, if you look at DOP study or if you look at other data from across the country in the United States, and I've talked to several of you here, and I think there is one published study that I'm aware of from India that showed that almost 50% of the fistula failed to mature, something called FTM. So dialysis access is certainly related with mortality. I'd emphasized that on my earlier talk, that patients with a catheter and starting dialysis with a catheter result in very high mortality. AV fistula are the preferred choice provided they work, because as high as 1 in 4 to 1 in 2 will fail to work. And after my patient has had 2 fistulae, 1 surgery, 2nd failed surgery, and now I'm trying to convince him that that catheter is bad, they're going to laugh at my face and say, "Are you serious? You just sent me to 2 surgeries, I've had 2 scars on my arm, and now you're telling me to get a 3rd one. Can you give me a guarantee that the 3rd one is going to work? Right? Will you give my money back for all the money that I've spent going and getting the surgery, even though the surgery is going to be paid by Medicare?" And I don't have an answer to that. So I think this problem is real, and this problem does affect and every nephrologist that takes care of the problem of these patients. And unfortunately, this problem has been there for almost 50 years, that fistulas are placed, but they don't mature. This problem was first highlighted by a Dutch nephrologist back in, I believe this was back in '96, that after you create a fistula, there are 2 processes that can occur. There can be an eccentric inward remodeling of that fistula or that fistula vein, which results in very thick vessel wall, but the lumen of the vessel becomes smaller, and that fistula will fail. As the lumen gets smaller, the flow gets low, and the fistula will collapse and stop working. What you want is a nice outward remodeling of that vein, so that once your fistula is created, and the fistula vein used to be 2.5–3 millimeters. After you create the fistula, within weeks, the fistula vein now becomes 6 millimeters, and the access is mature. How can we predict which vein will work, which will not? And when you dissect the vein, how can you predict that this patient is not going to have that dense inward remodeling, which we call neo-intimal hyperplasia, which is nothing but a maladaptive response of that vein to that stress and the inflammation that is caused by injury during surgery. The high flow is causing certain biological changes in the vessel wall, and the vessel is reacting with what the nature has told it to do, that whenever there is an injury, seal off and close off, and that's what ends up happening when the fistulas don't mature. So this neo-intimal hyperplasia is something that starts in the medial wall of that vessel but ends up in the intimal layer and results in severe reduction in the vascular lumen. When I think about a problem for failure to mature, I think we can look at this problem from 3 different perspectives. They could be patient-specific issues, they could be operator-dependent issues, and I think there can be some new technical interventions that have been used and are still being tried on to try and see how we can improve the outcomes in our patients. I think it's very important to recognize that fistula circuit starts at the left side of the heart and ends up at the right side of the heart. When you have a heart that's very poor, and patients who have severe symptomatic congestive heart failure, and you put in a fistula in that patient, the EF and the cardiac output was only 2-3 liters. The heart is not going to be able to pump extra, even though the peripheral vascular resistance has gone down after you've created a fistula. The cardiac output is not going to go up. So the fistula flows are going to stay really small, and the fistula is not going to mature. So we have to be cognizant of patients who are borderline symptomatic heart failure patients, and adding another cardiopulmonary bypass in those patients is just going to add to the stress on the heart. And you really have to evaluate those patients for reversible causes of cardiac dysfunction, reverse those before we create a fistula. We've come to recognize the minimal sizing of the arteries, and these are patient factors that sometimes you cannot change. And patients who have a very poor radial artery to begin with, these are patients, and the patients at risk for those would be patients with diabetes, severe peripheral arterial disease, patients who've been smoking all their life. And the radial arteries are only a millimeter, millimeter and a half. The ulnar arteries are really poor. These axes will not mature. And this data was published back from, I think back in '98, where they looked at the minimal diameters of the radial arteries and subsequent outcomes of the fistula. When you had at least a 2 millimeter artery, there was a higher likelihood of the fistula to mature versus the other way. The venous anatomy is also important to consider, and a vein size of at least a 2.5 millimeter is considered to be the smallest possible vein, because it has to get up to a size of at least 6 millimeters after the access is created. And another key component of that, which is never practiced, always talked about, is venous preservation. Now, one of the jobs of the vascular access coordinator and the nephrologist should be to discuss this early in the patient's CKD care so that you can preserve those veins. I think one of the biggest risk factors for finding veins that are not suitable for dialysis is the patient who's been coming to CKD clinic for more than 10 years. Because every 3 months when they come, they get venipunctures, they've got blood draws from that vein, and the vein has been traumatized and injured in that process. So preserving those veins early in their lifetime is important. There is a strategy being tried by one of the companies that I saw at last ASN. It's a really unique concept. The flow through the vein will cause the vein to dilate. Now, having said that, the arterial flow to the vein is considered to increase the stress on the vein, increase the shear forces on the vein, and leads to maladaptive remodeling. So what these guys did was they created a continuous laminar flow device, a little small pump that sucks out blood from the cephalic vein in the most distal part of the vein and puts it up into the axillary vein. And the patient wears this device for several days. That's what this device looks like. It's got a small battery that keeps it running. And the results were amazing, if you really believe them, that the outflow vein went from 3 millimeters up to 8 millimeters. And this was within 2 weeks of putting this device on. So now you get an 8 millimeter juicy vein to Dr. Shenoy. He's going to hit 100 out of 100 every time he creates a fistula on that. So getting access flow and getting the vein diameter could be a big change that can help create more fistulas. Age of a patient is another critical factor that you cannot change. And in several models, including one published by Dr. Charmaine Locke from Canada, when you see patients who are above the age of 65, the risk of fistula failure is going to be high. When I see the 80-year-olds getting fistulae, I sometimes really wonder why, because the vein is good, the fistula is good, but the subcutaneous wall, the subcutaneous support system of that fistula is so poor that the moment you stick that fistula, it's going to create a huge hematoma when you get that needle out. And then we also know that the average lifespan of an 80-year-old is maybe 2 years on dialysis. Then why do we need a fistula in those patients? So another topic of debate. But you really have to look at those patients' comorbid conditions and then the risk of failure before we decide what's the right access for that patient. And perhaps, considering the high risk of fistula failure in those patients, we should choose other options for dialysis. There are operator factors, the technique, the skills, the scope of procedures that they do. Do they do transpositions or not? Do they only create radial fistulas? Do they only create certain kinds of fistulae? Are they busy doing abdominal surgery, transplant surgery, and this is something that they just do once every week? Are all factors that influence fistula outcomes. And then we've highlighted the need to examine these fistulas after they are created. So once a fistula is created and nobody looks at them, you may have a patient who's got a tight juxtaanastomotic stenosis and they will have very poor flow in that fistula and nothing is being done. So two things can happen. Either the fistula stays like this or it'll end up clogging off within the next few weeks. A normal fistula should have good augmentation, which you can very easily do by palpating the pulse of the fistula, occlude the fistula, and now you get a water hammer bounding pulse, suggesting that the circuit is intact and the artery, which is communicated to the heart and is communicated fully open to that fistula vein, is all patent. They've looked at the experience of the operating surgeon, and they found that if the surgeons were doing 25 cases or less during their training, their failure to mature rates were very high, versus when they had an adequate training during their fellowship and these surgeons had adequate experience doing them, the failure to mature rates were really low. Nothing that we can change, but as nephrologists, I think it's our job to try and identify surgeons that are doing and have better experience, and then try and target your patients to go to those versus other people. Technical interventions can help. We talked about the injury caused by the conventional angioplasty. The injury can lead to more aggressive neointimal hyperplastic tissue proliferation. And in the arterial world, we've had drug-eluting balloon in both coronary and in peripheral arterial disease interventions, and they've been shown to be superior than conventional angioplasty alone. And the primary patency after a conventional angioplasty is about 50% or so. So a drug-eluting balloon is a device that will leave a paclitaxel or some other agent which will diffuse into the surrounding intima of that fistula that you just angioplasty and the stenosis that you just fixed, and should lead to better outcomes. And this is something that has been studied in a large randomized controlled trial in the United States just recently. The data is with FDA. They approved that device back in 2017. And the final study should be out in CJSON, I think this month or next month. So watch out for that. Drug-eluting balloons in dialysis access. Another device that has been studied was an OptiFlow device, which failed to show any benefit. The idea is that the angle at which the artery and the vein is anastomosed, if it's not adequate, then you will have higher risk of stenosis at the inflow. So you put this tungsten device right into the artery, and then you put the vein on top of it, and the phalanges are adequately secured to the wall of that vessel. And this leads to better flow and hopefully will lead to less failure to maturation rates, less technique failure. It should have less intersurgeon variability, which may be one of the causes for increased fistula failures. But like I said, one study that randomized patients into the device versus no device did not have any significant difference in outcomes. There's another device that I came across at the last ASN meeting, was a Vascu device. A very similar concept on angulation of the vessel wall, but this time these scientists from Israel, they figured out we don't really need to put something inside the vessel of the wall, which is permanent, but we can put a little casing on the outer aspect of that vessel wall so that we can support that angulation of that vein to artery anastomosis at an adequate angle. You can size that device to the size of the vein that you're creating. So if you're doing a distal radiocephalic, you can put a smaller device versus a bigger device. The device is secured within seconds onto that anastomosis after the anastomosis has been done, and it helps in more laminar flow with less shear stress. This device is still under investigation. There are no studies, there is no data out from this device yet. Another approach has been an elastase enzyme, Vonapanitase, has been studied in 2 studies where by application of a little elastase enzyme at the site of where you will develop juxtaanastomotic stenosis, you will prevent further proliferation of smooth muscle cells, and perhaps that will cause a better maturation rate. So there's been one study that did look at the outcomes, and the outcomes were favorable both in radial and the brachial cephalic fistulas, perhaps more favorable in the radial fistulas. This is still not approved for use, but could be another way that you can use to decrease AV fistula dysfunction. Just last month, we had 2 endovascular AV fistulas devices that have been approved, and I'll have another talk in the afternoon session on those. The 2 devices are Ellipsis and Everlink, 2 completely different pathways by which you create AV fistulas. With both of them, the benefit is that they are minimally invasive. They do not cause vessel injury. There is no scar to the patient. The patient don't need to be under general anesthesia for this procedure. The procedures can be done in outpatient setting, and the patients can go home the same day. So perhaps this may be the answer to this ever-lasting problem of failure to mature fistulas. So in summary, I think we really need to understand better why do access not mature, and then we really need to do our due diligence in identifying the right access for the right patient and match the right surgeon with the right technique to create that fistula so that we can get the best possible outcomes for our patient. The drug-eluting balloons show promise, but I think they do need to be studied a little more in terms of which lesion would respond better with a drug-eluting balloon application versus the regular conventional angioplasty. So with that, I'll stop and I'll take any questions.